Hi, welcome to Fertility Talks. I'm Mary Wong, founder of Alive Holistic Health Clinic, author of Pathways to Pregnancy, and your fertility maven. Today, I'm so honored to have Dr. Michael Virro with us, and we are going to be talking about ART and advanced treatment options, and really looking at immune therapy. And so before we go into the meat of all this, I'm just going to give you a little background. But first of all, thank you for being here, Dr. Virro.
You're welcome.
So he has been working in the field of fertility since 1982, and he's a founder and medical director of Markham Fertility Center. His focus is always on identifying problems for patients with multiple IVF failures, specifically the immunology of pregnancy, implantation, and recurrent pregnancy loss. His desire to help patients achieve a successful pregnancy is the catalyst for his continued investigations into a variety of treatment options. His philosophy is to provide personalized service, honest and direct answers, and medically safe, scientifically advanced, and ethically based treatment. And just so you guys know, I sought Dr. Virro out because he's one of the very few selected reproductive endocrinologists around the world that does a very specialized technique in terms of when it comes to immunology. But I'll let him speak to this. But first of all, the question I want to ask you is, why do patients fail IVF?
I think, well, to oversimplify, as long as you break it down into two factors, I think it's either a problem with the embryo, so the embryos aren't good enough, so they're failing because of that, or the embryos are good enough and they're not sticking. And they can not stick for a variety of reasons: anatomical problems with the uterus, endometrial receptivity problems, or immune factors, and that's what we sort of specialize in here. I think, just to throw it out, if we're talking about this in general, the biggest problem that I face is advancing maternal age. And I think if we're going to get any message across today, is it's hard to make good embryos as a woman gets older. And, you know, aneuploidy rates, abnormal embryo rates increase as you get older, you get less eggs. I think the average age of my patient is 38, and they come in here and they think, well, I'm going to make 3 or 4 good embryos and get done with this. And at 38, we're lucky to get 1 normal embryo per cycle, and it's hard. So I think if we're going to say, yes, there's implantation problems, there's embryo problems, but I think the biggest problem that I deal with is just advanced age. And I think if, you know, I get it. We got jobs, we got, you know, the economy's expensive, everything, housing in Toronto's expensive, but if couples can start focusing on having kids earlier, my job will be infinitely easier. And I guess I'm lazy. I like easier than harder. So,
you know what, I can't agree with you more, but we're not here to make people feel bad about their situation. That's for sure.
No, that's for sure.
And certainly I believe that it's a social issue, not just an individual issue. Right? Because, and socially and financially, right? It's a cultural thing. Everybody is getting more educated, and since women's liberation, women are seeking higher education, and really it's the last thing on their mind is fertility, right?
Nobody expects they're going to have an infertility problem.
No. And this is where I say, gosh, like we should be speaking to this when kids are in school, like high school, because all they worry about then at that point is how not to get pregnant. So the assumption is that, you know, you could just look at each other and get pregnant, and then when the time comes to whatever age you are, it'll happen like that.
That's the expectation, and you're looking at a person who looks at it through tainted eyes. I don't think anyone can get pregnant. So,
yeah.
So, you know, we just deal with the problems here. So,
right.
But I think, yes, I mean, I think what you just said is very important, and we're not here to tell them what to do, but it would make life easier if they got going earlier.
Yes.
I think,
yeah. And so with that, the other thing I got out of what you just said is when people look at a failed IVF cycle, and aside from the embryo quality, which is huge, I mean, the percentage of it being aneuploidy would be much higher than just looking at, I'm not going to downplay the endometrial receptivity because that's there for sure. But the biggest piece is about the embryo, isn't it?
Well, it all starts there. I mean,
Yeah.
it starts with ovarian reserve. I mean, it's easier to come up with a good number of embryos if a woman is starting with a good ovarian reserve. So starting off with 10 eggs after stimulation is infinitely easier than starting off with 3 eggs.
Mm-hmm.
So it starts there. A normal fertilization rate in our clinic is about 70%. So if you start off with 10 eggs, you'll have 7 embryos. You do a blastocyst culture, the normal blastocyst rate is about 50%.
Okay, wait, we need to back off so not everybody understands this.
Okay.
So a blastocyst, right, is after, so you do an IVF. First of all, actually, some of you don't even know what IVF is, right? So IVF is when you take the man's sperm, the woman's egg, you basically put it in a Petri dish, and if you do ICSI, which is injecting a sperm into an egg, or just naturally letting it fertilize it in Petri dish, so to speak, right? And then once it fertilizes, then you wait and see if they develop. And the blastocyst is typically about 5 days after it fertilizes. So it's expanded, and you want to expand on that?
Yeah, after about 5 to 6 days, the blastocyst should be about 80 to 90 cells, a good one. And that's what you want to see. That tells you a lot about egg quality. Is the sperm good? So it takes a lot of energy for an embryo to make it to the blastocyst stage.
Mm-hmm.
And only about 50% of embryos, somewhere around there, will make it to the blastocyst stage. So if you start off with 10 eggs with a normal fertilization rate of 70% and a normal blast rate of 50%, you've got 3 embryos starting off from 10. I think couples look, wow, I've got 12 eggs, I'm going to get a lot of embryos. It just doesn't work that way. Then you throw in, if you do genetic testing, which I think is extremely important nowadays, at the age of 35, half of the embryos are genetically abnormal. So let's say you got 4 blastocysts, now you're down to 2. At 38, it's 60%. And at 40, it's 75%. So you get 3 embryos in a 40-year-old, you'll be lucky to get 1 normal one. So then we're talking about a 2nd cycle or a 3rd cycle, and that's just doing things normally. That's when there's good ovarian reserve. So again, if you start off a woman who's only making 3 eggs at the age of 40, we're basically planning on we might need 2, 3, 4 cycles to get 1 good embryo.
That's right.
It's
so
hard. It's hard.
It is difficult, and that's why more and more women, or more and more clinics are now using batching. So you do a bunch of IVF retrievals before you even think about putting them back, and especially adding in the pre-implantation genetic testing or screening or whatever they call it these days. So okay, which brings me to question number 2. Why is the genetic testing important?
Well, I'm an old fart, so I've been doing this for a long time, and I was at one of the first IVF clinics, the first one in Toronto in the 80s. I mean, all the guys I trained up have passed. I mean, I'm getting to be old. But, they were the pioneers back then. I mean, and we were uneducated back then. I mean, we were doing inseminations with 5, 6, 7 follicles. We were transferring 5 embryos. I mean, we were getting triplets, we were getting quadruplets, we were getting quintuplets. We just didn't know any better. And I think, if anything I've learned over the years doing this, we are getting better and better, and we are getting wiser, as we should be, as with anything else. So now it's all about a single transfer. In my opinion, you put in just 1, that eliminates all the potential complications of a twin pregnancy. If you do genetic testing, from a physician point of view, starting off with the right embryo helps, especially if a couple has a negative test. Mm-hmm. So if a 38 woman has an IVF cycle with an untested embryo and she miscarries or it fails, the first thing that a physician will think is, well, if it was an abnormal embryo, it's not going to work anyway. So when a couple comes to see me that has had multiple IVF failures, that haven't done genetic testing, now you're trying to piece together failures with untested embryos, and theoretically if 70% of her embryos were abnormal, 70% of her transfers had no chance of working in the first place. So I think by doing genetic testing, it certainly helps us from our point of view. If you get a negative test, you can't blame it on the embryo. Now, is genetic testing the world's perfect test? No, but it's sort of the best we got, and you've got to go with that.
Right. Well, so it's basically not, meaning it's not 100%, because not all genetically, chromosomally normal embryos are babies.
Correct. And,
Right.
you know, our pregnancy rate here with the transfer of a euploid embryo, genetically normal embryo, is about 65%. So that leaves 35% of implantation, uterus. Is there something else with the embryos? I wish I could say 100% about anything today, and we can't. But I think, again, it all has to start somewhere, and to me, starting off with a genetically normal embryo is step one. So I, with my patients, strongly counsel to do genetic testing. Yes, it's an additional expense, but I think it's probably the best money spent. And what couples, I think, don't realize is it becomes, in my opinion, even more valuable if you fail. Because if you fail with genetically normal embryos, that to me says we've got to look now at implantation problems,
Right.
and whether it's endometrium, but that says, I think this embryo is okay to the best of our testing. We need to focus on the woman and implantation. And it helps sorting things out.
So are you doing genetic testing even for the younger ladies?
Yep.
Okay.
I mean, we've had 2 cases here in the last 6 months. Anecdotal medicine's bad medicine, but 2 egg donor cycles. Both donors are 28. Both couples made 10 blastocysts, which is a phenomenal cycle. So
That's
10
great.
blastocysts, we're going, wow. We did genetic testing for both of those couples, and actually 70% in both cases, so 7 out of 10 embryos were genetically abnormal. We would have expected the opposite. 7 would have been normal, 3 abnormal. And so what we did in those couples is we saved 7 transfers of embryos that basically didn't have a chance. Now you can say, wow, they had only 3 normal ones, but you could also argue we just saved, you know, how many dollars a transfer, a frozen transfer, whatever the clinic charges. And it's not even that, it's the emotional toll. You know, I've spent this money for an egg donor cycle, I've got 10 beautiful, we think beautiful embryos, and I keep failing. They're going to start wondering, why am I failing? Is there something wrong with me? When the answer is sitting right under your nose,
Right.
It's an abnormal embryo.
Yes.
So at least we've eliminated the 7 failures right away, and now we're dealing with 3 embryos in those cases, which have a chance. Genetic testing has opened up our eyes, I think primarily, there are a lot of abnormal embryos out there. And yes, it gets worse as you get older, but we sort of think a young woman's not going to have any abnormal embryos, and I've just given you 2 examples. And we see, I've got a family member that had a very high aneuploidy rate, and she was young.
Right.
So you just don't know until you do it. But we see embryos that we didn't even think existed. I mean, we're not just talking about trisomies and, you know, the ones we see, Down syndrome. We're seeing these multi-complex abnormal embryos that just don't have a chance. And to me, there's no point putting in any embryos as of 2019 that have no chance.
So just as an aside, does your clinic, do you guys put in mosaics?
We as a rule, we have not done we've done a few. So, I mean, that's sort of the hot topic right now with pre-genetic testing. Do you transfer a low-level mosaic embryo? So, a mosaic embryo is an embryo that some of the cells are normal and some are abnormal. And so the theory is that if you put in a low-level mosaic embryo, it can correct itself as you go along and get a normal child.
Right.
And it's been documented that can happen. I think it depends on the level of low-level mosaicism
Right.
that's in the embryo. And so we sort of have criteria here that we don't want to transfer anything above a certain threshold. But our philosophy is we would leave that embryo as the last sort of ditch option. You know, you see it more in older couples that are struggling to make a normal one. But if we have a genetically normal euploid embryo or several, we would definitely use those first, and I think everybody would.
Of course,
before
of
you
course.
you use the mosaic.
Yeah. Okay, that's fair. And well, let's talk about immune therapy, because we're now talking about, okay, you have a chromosomally normal embryo, PGS tested, or PGT now, and you had, let's say you had a couple of normal embryos, right? And then you had 2 failed cycles. It's like, oh my gosh, now what?
Well, I see your fourth question, so I think 3 and 4 go together.
Okay.
So 4 is what factors determine the perfect transfer. So here, I think step 1, we've already said, is get the best embryo we can with genetic testing. So let's say we have 2 genetically normal embryos on ice sitting in the bank. Now we've got to get that embryo to stick. So an ultrasound or a sonohysterogram, a hysteroscopy, whatever you're going to do to determine that the uterine shape and cavity is good, I think that's step 1. We don't want to transfer, as a rule, with endometrial polyps, a fibroid in the cavity, a uterine septum. We want to make sure the structure and integrity of the uterus is good, and that's been done well before the IVF has happened.
Right.
Endometrial receptivity testing now is I think extremely important. An ERA biopsy. So you do a biopsy of the endometrium, which basically says this is the time to put the embryo in. So once she ovulates, either with a natural cycle or a medicated cycle, when you're ready to put the embryo in, you want to put the embryo in at the right time. The numbers in our clinic, which was a little shocking when we started doing these things years ago, about 20% of the time we were actually putting the embryo in at the wrong time. So now you've done all this work to get a perfect embryo. The window of implantation, depending who you talk to, let's say is 12 to 24 hours. So you've got that window to put the embryo in, the blastocyst in. If we put it in outside of that window, all that work to get that embryo has no chance because it was the wrong timing.
Mm-hmm, mm-hmm.
So by getting the right embryo, making sure the uterine environment is correct structurally, and now timing for receptivity, I think those are the first steps.
Right.
And if we're good with that, I think you do a transfer. Where we leave the immune testing for is couples with multiple failures under those circumstances, or if they've got a history of some autoimmune disease. So I think you have to individualize. But the immune treatment and testing is, unfortunately, very expensive. We send our tests off to Chicago. I mean, it's $3,000 US just to get the testing done. And we're looking at natural killer cells, cytokines, leukocyte antibodies, antiphospholipid panels, clotting factors. So you're trying to get a sense of what's going on with this environment in the woman's body. So it's expensive just to do the testing. Under the category of multiple IVF failures with normal embryos, normal uterus, normal timing, we will find immune issues almost always in those patients. And that philosophy started here 25, 30 years ago. We didn't have genetic testing back then. We didn't have even blastocyst cultures back then.
No.
But we never liked the concept of having multiple IVF failures and doing the same thing over and over again. So we said, let's look into the immune stuff, which we did back then. And back then we just started giving IVIG, and we immediately, it was like crazy.
So let's tell
success.
everybody what IVIG is.
So you do the immune testing, and we usually discover problems. And again, oversimplifying, natural killer cells and cytokines we think are the cells that will attack an embryo. And an embryo is a foreign body.
That's right.
The embryo is half of the wife's DNA and half of the husband's DNA. So the question that these guys, Alan Beer, and they asked, and it was the late 50s, this has been around a long time.
Mm-hmm.
I think the question that needs to be asked is why a woman doesn't miscarry every time she gets pregnant, because it is a foreign body.
Right.
So we do believe, or I firmly believe, that the immunology is definitely important for an embryo to implant. So if you believe in that, then I think you should believe that that immune system can mess up. And what we often see is the elevated natural killer cells, the cytokines, which we think attack, and the leukocyte antibodies we think are the protectors. And what we often see is you want to see the high protectors and the low attackers, and it's the opposite. So they have no cells to protect, their leukocyte antibodies are really low, and their cytokines or killer cells are really high. And we've got to get that reversed. The treatment for the low leukocyte antibodies is something called LIT, which is lymphocyte immunization therapy. We take the husband's white blood cells, prepare them, inject them into the wife's forearm, and it evokes an immune response to get the leukocyte antibodies up. It's usually very effective, and it's pretty easy to do.
Mm-hmm.
To bring the cytokines or the natural killer cells down, we have multiple options. We can do intralipids, which is a transfusion of a fat solution. We can do steroids, prednisone or dexamethasone, IVIG. That's the big ticket item, which years ago we got for free. I mean, the government paid for it, now they don't. So IVIG is basically a blood transfusion of pooled immune cells. And most patients get 2 bottles, 40 to 100 cc's based on their weight. But to get 2 bottles of immune cells, it's probably about 1,000 people that have had to donate their blood.
Right.
They fractionate out the immune cells, and it's expensive, and it's a long process to do
Yes.
that. But I think that's also why it works, because you're getting this diverse population of immune cells. It's helping those leukocyte antibodies and natural killer cells doing all the right things at once, making the environment better to make that embryo stick. I mean, that's oversimplifying,
But we get the gist.
yeah.
And so for you guys watching out there, it's not readily available. It's not every clinic does this. In fact, in Ontario, you're the only clinic that I know that does the IVIG and LIT.
Yeah, I think we're the only ones doing LIT. I've heard some reports now, some guys are doing IVIG and intralipids,
Really?
but I couldn't give you a list. But
Okay.
Yeah.
But so, back in the day, I remember before you even did it, I've had some patients that would go to Mexico to do the
Well, we sent
LIT
patients to
treatment.
Mexico
Yeah.
for LIT for a while there, 5-7 years ago. Thank God, no problems. And again, it was one of those things when we started doing it, we had immediate success.
Mhm.
I mean, a lot of my patients ask, how come you're the only ones doing it? And I believe there's this philosophy out there that the immune therapy is hocus pocus and it isn't important or whatever. And I just disagree. We just have too much experience, thousands of patients that have done this. And we're not talking about first-time IVF, we're talking about patients with multiple IVF failures, even pre-genetic testing, pre-blastocyst, but still, the criteria has been the same. Multiple IVF failures, why am I not getting pregnant? And all we do is do this immune treatment, and for 30 years we've got it ranges from 60 to 75% pregnancy rate in couples with multiple IVF failures. So, is that just a fluke with 2,000 patients? I just fail to believe that. I mean, we've published on this, we've got evidence-based medicine that they've got these levels before the treatment, these levels are fixed after the treatment, and then they get a pregnancy. So I think it's just a philosophy of how you look at things, but we've always felt that immune therapy is very important. But in the group of patients with multiple failures and multiple miscarriages.
Right. It's not an automatic go-to.
No, it's not an
You have one failed cycle and you're like, oh, I'm going to go straight into immunotherapy,
No,
right?
no, yeah.
Okay. I really love that you're saying this and how you're being sequential about this whole process.
Yeah, and the multiple miscarriage group is the harder of the two groups. I mean, the multiple failed IVF is actually the easier group that respond better to the immune stuff. That miscarriage group is a tougher group, no question. I mean, still, we've had lots of success, but looking at the two groups, they are different. And that miscarriage group is a tough group.
Okay. So, but meaning that with the multiple miscarriage, you're still getting some...
Oh, still very good numbers. But again, they've had the normal investigation for the miscarriages, the karyotypes of both, the uterine factor ruled out, whether you do mycoplasma testing. There's the standard group of tests you do for miscarriages. So we've done all that. But again, looking at the multiple miscarriage group, I think the first step is getting the IVF genetically normal embryo.
Absolutely.
Because
Absolutely.
if all the immune treatment in the world will not help a genetically abnormal embryo implant.
Yes.
So why would I make you, if you were doing a cycle, pay $4,500 for IVIG if I think you needed it, starting off with a genetically abnormal embryo?
Right.
That's just a waste of $4,500.
Absolutely.
Yeah.
Yeah. Thank you for that. So, oh wait, is there a question? Which FET protocol in use with use of immune therapy in natural versus medicated FET cycles?
Well, that's a good question. That's a really good question. We've been looking at this for a long time, and just recently here we looked at it again, and I'm talking about 2 weeks ago.
Oh wait, FET means frozen embryo transfer.
Our pregnancy rate in this clinic is very statistically significantly better with a natural cycle. It is actually a little scary. So we've always liked to do our frozen transfers on a natural, non-medicated cycle. We just
Love
monitor
it.
through the woman through the cycle. We document the day she ovulates. Usually we've done an ERA biopsy to determine the timing and put the embryo in. I just think there's less likelihood of having a progesterone deficiency, bleeding problems or spotting with the medicated cycle. And here it's a very significantly higher pregnancy rate on a natural cycle. So if we have a natural cycle option, that's our go-to cycle.
That's great. So wait.
But
so
some women can't have a natural cycle. So women that don't ovulate,
Sure, right.
they have to do a medicated cycle.
Right.
Perimenopausal women, or you may have some lining issues. Some women have to do a medicated cycle, but if we can avoid a medicated cycle here, we would prefer that. We're also here every day of the year. Well, we close over Christmas, so we don't care if there's a transfer on Saturday or Sunday.
Sure.
So, I wish we could get all women ovulating between Monday and Friday, but it doesn't happen. But that's our philosophy. If that's our better pregnancy rate, we should do transfers on Saturday and Sunday if that's the day it hits. Yeah.
And then, so when you're talking about in these natural cycles, then you're doing the ERA testing on a natural cycle.
On a natural cycle as well.
I have never heard anybody say that. I love this, guys. You got to really take notes and.
Well, and we're talking thousands of, this isn't small data, small numbers. It's significantly better with a natural cycle here.
Love that.
Well, it's what we got to do what's best.
I absolutely versus convenience.
I would love not to work on Saturday or Sunday, but we got to do what I think is best. I mean, if we stop doing that, I think we should stop practicing.
Oh gosh, that's amazing. That's certainly women ask me all the time. So I'm in the more considered the holistic field. So I don't know if you know this, but because of that, we're considered unbiased. So oftentimes the patients come to us and ask, what should I do? So to hear that is excellent.
Well, it's striking in this clinic. Yeah.
Okay, great. Here's another one. Is there a higher incidence in positive outcomes in one over the other?
Natural cycle.
Yes, okay, so yes, natural cycle, okay. And this is Melanie. And Melanie Mitchell is the IVF nurse, and she, I did a post with her a couple of weeks ago where I offered my butt, and I actually self-administered, which I had never done when I went through IVF. So I was so impressed with other women doing it by themselves. So I thought, gosh, I have to show other women how to do it and empower you. And certainly I did, and that was like 2 posts ago, so check that out. Any other words of wisdom that you want to add in? I love that piece of it.
Well, I think wisdom's a good word. I mean, the longer you do this, I don't know if I'm getting smarter, but I'm definitely getting wiser. I mean, I wish we had 100% pregnancy rate. I mean, that is the goal. I mean, we get frustrated, I know how much couples put into this. I mean, the government for the last 3 years has offered the funding. I don't know how long that's going to last. Who knows? That's helped enormously with some couples that can't afford IVF. But it's a huge time commitment. It's an emotional roller coaster, financially. And there are unfortunately some cases. I just put my hands up, and we've done everything by the book. We've done all these things we've talked about today, and we still get failures. And until we fix that, I think we still have to keep looking. And again, 35 years doing this, every year, 2 years, something new comes out. We are getting better at this. And as long as we take those treatment strategies that are safe and apply them and just don't do the same thing over and over again. I think Einstein said that. That's the definition of insanity.
Yes.
Just keep, doing, look at the studies, look at the data, try different things, and we're still going to fail. One of these days I'm going to put a sign on my wall. I don't want to fail. None of us want to fail, but I think if you fail for the right reasons and you've done the best you can, the best treatments as of May 3rd, 2019, we know we're going to fail every once in a while, but I also know we're going to win 2 out of 3, 65, 70% of the time. That's not great, but it's not bad, but we got to get better.
Mm-hmm.
I mean, so that's our goal, to just keep getting better. And I always, you talk to these, Michael Jordan's, the great athletes, and you say, what was the best thing? And they all say the same thing, and I'm not comparing myself to them, but you look back at the couples that you failed with, and that's what bothers me the most. I mean, you get close to these couples, you know them, they come in here, and they've had multiple failed IVF cycles, and those are the ones that I remember. We sort of let them down. I mean, we just got to try to keep getting better.
And to add to this, though, right? It's not just about you. They come to you and seek help, and you do your great stuff. But ultimately, too, there's onus on yourself, right? Looking at your lifestyle and dietary habits. I think that's also very important. And
yeah, let's not I mean, I think if you would have asked me that question 15 years ago, I probably would have brushed it off. But I do think, I've got one daughter who's a master's in nutrition and psychology.
yes.
And she's, I think there's a lot of data emerging with lifestyle, dietary. I mean, we've done a lot of research here. Keto diet, will that
Yes.
help egg quality? Absolutely. I think couples, if they can be healthier, the overweight patients, if they can lose weight, all these factors contribute to this. I mean, it's not just the culture medium, it's not just the egg quality. I think it's a combination. It's a very good point. I think if we can get the couples focusing on being healthy, it will not be detrimental. If anything, it'll only help us.
Thank you.
Yeah.
So the very last one is, when do we call it quits? If things aren't happening, when do you call it quits?
I've always felt my gut has served me well, and I think, if we've done everything according to plan, with all the steps we've talked about today, and we're failing, I think at some point you just have to say it's either time to quit. If there's been an egg quality issue, is it time for an egg donor? If it's the sperm, is it time for a sperm donor? If we're having multiple failed implantation, is it time for a surrogate? I mean, these things are all open for discussion. I actually think most people will quit because they've run out of money, or it's not that they want to quit, they just can only do so many of these cycles.
Well, and emotionally,
And
my goodness,
emotionally,
it breaks
yeah.
you down.
And emotionally.
Yeah.
I think it's our job as a physician, and some criticism I certainly get is I'm too blunt and too direct. But I actually think if you don't give patients the honest numbers, and I'm not saying nobody is not doing this, but I think it's our job to tell patients what their odds are, what we're up against. And I've always said patients aren't stupid, let them make their own decisions. I mean, there's 3 people usually sitting in this room. Let's make a plan that makes sense to all of us and let the numbers hit where they're going to hit. But we've got to be honest. If I've got a 45-year-old woman comes in here and she's expecting me to say she's got a 90% pregnancy rate, she's come to the wrong place. I mean, I can't look her in the eye and say, I can't. I mean,
No.
we start that conversation by saying it's probably not going to happen. Is that the right answer to give her? I don't know, but I don't think you can sugarcoat something like that.
Right.
Yeah.
I think that's very fair. It's all in how you deliver it, though. So I have
Absolutely.
to say, there's a lot of docs out there, and some that are more able to deliver the news, so to speak. in a compassionate manner, and other people that are very stats-based, and then it leaves many women, most women, walk out of there quite broken. And what I tell you is, you're not broken. It's just, how can we optimize with what you've got and go from there, and be open-minded, as you're saying, because really it's not just, oh, am I going to go child-free or am I going to do IVF, right? There's lots of things in between.
Well, this broken word you say, I think is an interesting word. Quite often during my lifetime, you hear, oh, I've had bad luck, I've too much bad luck, maybe I shouldn't be pushing it. You quite often, they've got 1 or 2 kids and are wanting a third. Am I pushing the envelope? I don't think infertility is any different than diabetes, cardiac dysfunction. If we're going to believe this is the way God designed it and that this is the way it's supposed to be, then if I drop down with a heart attack right now, then don't resuscitate me, because God said I'm supposed to die today. If you've got diabetes, we should let it go uncontrolled because God said it was supposed to be that way. I don't think infertility is any different. People aren't asking to be infertile. There is usually a problem. Whether it's endometriosis, low sperm counts, not ovulating, we're here to fix that problem. Just like anything else.
Okay. And as we try to fix, it doesn't necessarily mean it's the end-all be-all, right? And it certainly is not 100% for anything. So.
Never once said 100% here. I wish
Absolutely.
I could. I wish I could.
Yeah. Well, I understand, and I completely acknowledge the way you are as a practitioner. I love how you're being so authentic about this, and not just to say, hey guys, you do immunotherapy and I'm going to get you pregnant tomorrow. No. It's not that easy.
I wish it was.
Yeah.
I wish it was.
All right. Okay, I don't want to belabor this, and thank you all for watching. And go scroll down. There's 125 videos, so I'm sure you'll get something out of something. And even some of the things that we covered here, we have covered in the past. So check that out. Check my book out, Pathways to Pregnancy. You can go to marywong.life and get a chapter for free there, or just go and order the book. And so we shall see you next time. And I think next week we're actually going to talk to a former IVF patient who is now currently carrying twins. So we'll love to hear that story. So have a great day, and we shall see you soon. Take care. Bye for now. Thank you.
You're welcome.